Good morning, ladies and gentlemen. The topic given to me is glycemic variability and hypoglycemia. And this is the flow of my presentation. To start off, whenever we manage diabetes, we need to remember that there's something called the triad of diabetes care. Our entire aim in the management of diabetes is to improve outcomes. The glucocentric view has disappeared, and I think that's the wrong approach in managing diabetes nowadays, just looking at the glucose values and adjusting the dose of the drugs. Those days are gone, I think, more than a decade now. It's looking at the outcomes, which is more important. It doesn't matter if the sugars are high, remains high, but provided we take care of the outcomes and prevent most of the complications. We have been hearing of GLP-1, SGLT2 a lot because these are the drugs which can improve the outcomes of diabetes-related outcomes. But what about the natural outcomes of the combination of drugs that we use, especially insulin or sulfonylureas, which are known to cause hypoglycemia? And a way of explaining that is via this term called glycemic variability. And a lot of people will come up with this term glycemic variability. It's doing rounds for a pretty long time, but I will show you that it's just a term and it's just for an academic discussion. We have seen with the gliptins coming into the picture when the sulfonylurea became one of the favorite topics to bash, this glycemic variability came into the picture. And glycemic variability clinically is very easy to demonstrate and tackle because it means glucose going up and glucose going down. But then what is very important to understand that there are certain mathematical values which the glycemic variability has been attributed to, which we never use in clinical practice. And that is where we need to ask ourselves the question whether glycemic variability is an independent clinical outcomes that we want to look at, or is just hyper and hypoglycemia, which we are taking care of as it is when we manage our diabetic patients. If it is hyper and hypo, then there's no need of dealing with a term called glycemic variability. And this is the slide which I think summarizes that whole issue. If you find out there, these are all the glycemic variability parameters, which are the mathematical models which had been developed. For intra-day variability, that is within the day when sugars are going up and down, it is measured by models such as MAGE and CONGA. And between days, day 1, day 2, day 3, day 4, when we have glycemic variability, it is measured with standard deviations. And other, we have like 1,5-alpha-glucitol and so on and so forth. Now, I'll ask you, how many of you do this? None of us do this. We cannot sit down and do calculus and differential calculus and integration, which are all part of these mathematical models. And most importantly, even if we do it, does it make any sense? Did it make any difference in outcomes? And we had this, 4 classic examples. Heart 2D and Navigator trials were done with nataglenide and with prandial insulin after fasting sugar, and HbA1c was perfectly under control. And whenever we had the sugars going up and down, they wanted to look at the outcomes, what difference did it make? And there was no improvement in any of the outcomes, whether it's micro or macrovascular outcomes. Look at the DPP-4 inhibitors, which are supposed to have lesser glycemic variability compared to a sulfonylurea. And look at all the DPP-4 inhibitors with cardiovascular outcomes, even the head-to-head trial against the glimepiride in the Carolina trial, where is the difference in outcomes? Definitely there was lesser glycemic variability with all those measures with the DPP-4 inhibitors. We didn't find any improvement in either macro or microvascular outcomes. And then we had the glycemic variability attributed to postprandial hyperglycemia, and we had the very recent ACE trial done in IGT patients with acarbose. Again, there was no difference in the outcomes. So glycemic variability, as rightly summarized out there by one of the meta-analysis, to date, the causative role of glycemic variability in oxidative stress and cardiovascular disease in patients with diabetes remains controversial. It was thought to be related to antioxidant, and none of the antioxidants had given us any benefits as far as outcomes are concerned. So first of all, let us forget this glycemic variability part. It is just a theoretical discussion. There is no outcomes benefit. So what does glycemic variability predict? From a clinician's and from a clinical point of view, it is important for you and me in identifying hyperglycemia and managing hyperglycemia without inducing hypoglycemia. Again, I'll come back to the point. This is what we are doing day in and day out. So it's nothing novel that glycemic variability is bringing on the table. This is a sort of slides which have been showed to us over and over again with CGMS. When the A1C is 6.7 in 2 different patients, in one it is flat, another patient it is going up and down, and hence it is bad. I again come back to the point. Where is the data that it is bad? There is no data as of now. But hypoglycemia is important, and hypoglycemia is one of those components of glycemic variability. And we must see to it that severe hypoglycemia does not develop, and that is the second part of the presentation, which I'll show you. Because once we develop hypoglycemia in a patient who has not yet achieved glycemic control, then what happens that dose titration stops, and the patient also doesn't want to titrate the dose, and then the patient remains in uncontrolled state throughout. That is the clinical dilemma that we face when our patients develop hypoglycemia with an A1C, say, of 8 or 9 or 10. That becomes a big problem. So this brings us to the issue of hypoglycemia. Again, we will have to ask ourselves the question, was hypoglycemia overplayed, overdone, and overmarketed in scientific forum? Is all hypoglycemia bad? Is mild hypoglycemia bad? Or is moderate, which is bad? Or is severe, which is bad? We have to understand these things. The rates of hypoglycemia in type 2 diabetes are not as explosive as in type 1 diabetes. I can understand type 1 is a different ballgame, but in most of the scientific session when we talk about hypoglycemia, it's type 2 diabetes. And remember, the rates of hypoglycemia are much, much lower in type 2 compared to type 1 diabetes. Now, one thing has been proven through mechanistic study, and this is the nocturnal hypoglycemia data. And if you look at this, through proper Holter monitoring, it has been documented that if you have nocturnal hypoglycemia compared to daytime hypoglycemia, the rates of bradycardia, atrial ectopic, ventricular premature beats goes up. And these are statistically high values that you have with nocturnal hypoglycemia. And it's precisely the reason why you find that a lot of insulin development was focused on basal insulin, because these are the drugs which actually affect nocturnal hypoglycemia. So you find a lot of developments happening positively with basal insulin, not with the fast-acting rapid insulin. The development of that is actually more of a marketing strategy. There's not much of an improvement with any of these drugs compared to the conventional prandial insulin that we are using. So if you look at these trials from the ACCORD and ADVANCE trial, again, ACCORD has been overplayed. No one knows why that increased mortality happened in ACCORD trials. Many people attribute it to hypoglycemia, but there is absolutely no data to prove that hypoglycemia was responsible for the increased mortality in ACCORD trial. But if you do a post hoc analysis, for those who are fans of post hoc analysis, I am not. I think these are ways of writing more papers, nothing more than that. You find that severe hypoglycemia was associated with increased mortality in the ACCORD as well as in ADVANCE trial. And this is the DEVOTE trial. As I said, most of this hypoglycemia and nocturnal hypoglycemia data comes from basal insulin trials. DEVOTE was glargine versus degludec. Again, you find those with severe hypoglycemia has significant differences in MACE as well as all-cause mortality. Let me again tell you, this is also a post-hoc analysis. This is not the primary analysis of the trial. So where do we have actual primary analysis data that hypoglycemia is bad? And it comes from only one study. It's called the Edinburgh type 2 diabetes study, where patients were put on whatever glucose-lowering regime, and whether you have a single episode of severe hypoglycemia or not was registered. These patients were followed up for 4 years. And you find that there is a significant increase in macrovascular disease, coronary heart disease, and MI in those who have even one episode of severe hypoglycemia in the past. Once again, you see, I keep on repeating myself when I'm saying severe hypoglycemia, severe hypoglycemia doesn't have a value. Severe hypoglycemia means any hypoglycemia which requires external assistance for correction of the symptoms. There is no value attributed to it. To get a complete picture, we today know that although we talk of glycemic variability, the predominant contributor is severe hypoglycemia, which drives these outcomes. But the question is it only severe hypoglycemia? So if I want to take a take-home message from this presentation, from tomorrow, moderate and mild hypoglycemia, am I going to take my patients, oh, that's fine, don't worry? No. Because if we have multiple episodes of moderate to mild hypoglycemia, what we develop is something called the hypoglycemia unawareness due to autonomic neuropathy. You know, the set point goes down, and because the set point goes down, if you have hypoglycemia, the norepinephrine and epinephrine response disappears. Patients won't have sweating, patients won't have palpitation, they won't recognize those hypoglycemia. And the first symptom may be sudden cardiac death or severe hypoglycemia requiring hospitalization. So yes, we also need to bother about mild to moderate hypoglycemia, because if the patient develops hypoglycemia unawareness, there is near about 2.5 times higher risk of developing a lot of problems, including mortality and morbidity. This is my last slide. We need to remember that the cause and effect relationship between severe hypoglycemia and mortality can only be deduced by one trial, and that's the Edinburgh type 2 diabetes trial. Rest of them are all post hoc and sub-analysis. It's just drawing conclusion forcibly in order to sell molecules, nothing more than that. But more than that, what we need to understand, the glycemic variability doesn't have a cause and effect relationship with any outcomes that we are talking about. Again, it's a drug selling model that has been used over and over again. But high glucose variability, if it is hyper and hypoglycemia, it is well documented and there is a mechanistic basis. If it happens repeatedly, it can bring about epigenetic changes, which not only develops in hypoglycemia unawareness, but is responsible for increase in obesity, hypertension, as well as development of future cardiovascular disease because of the epigenetic changes, which can happen in a short span of time, unlike genetic changes, which takes a longer duration of time. So these are the agenda I started off, and I'll end with saying glycemic variability and outcomes. In red, there is no data. There's a big question mark. We have no data to prove that if your A1C is normal, your fasting sugar is normal, documenting glycemic variability and trying to do something about it, will it make a difference in outcomes? The answer is no. We don't have any data as of now. Glycemic variability, it predicts the development of future hypoglycemia. So if you and me are not confident in detecting hypoglycemia, whether we should do CGMS to detect glycemic variability, think about it. I don't think I need a CGMS to do that. You know, a simple SMBG gives me a good picture of development of severe hypoglycemia. The severe hypoglycemia and adverse cardiovascular outcomes is a proven reality. So we have to use such combination of drugs which prevents development of severe hypoglycemia. We can get away with mild to moderate hypoglycemia if they are less frequent. OHAs reducing glycemic variability and severe hypoglycemia like the DPP-4 and SGLT2s and hence giving outcome benefits is a question mark. We have no data on that. Insulin and reduction of glycemic variability and hypoglycemia, yes, there is proven benefit, but remember, these also comes from post-hoc analysis of the DEVOTE trial. Now it's up to you to decide whether you believe it or not. So, ladies and gentlemen, I will just summarize this topic by saying, yes, glycemic variability is important if you think of it as managing hyper and hypoglycemia, not doing an SMBG and detecting glycemic variability. There is just no data to prove that it makes any difference in outcomes. Thank you.